Medical assistance in dying. MAID represents one of the most profound and personal intersections of modern medicine, individual liberty, and the law. It is a medical process through which a qualified health professional, such as a doctor or nurse practitioner, provides assistance to help a person who has made a voluntary and informed request to end their life. In Canada, this is not an abstract concept. It is a legal and regulated part of the healthcare system. The framework surrounding MAID is designed to be structured and methodical, ensuring that such a monumental decision is never made hastily or in a casual manner. It is a process governed by strict rules. The conversation around MAID is often fraught with emotion, touching upon our deepest beliefs about life, suffering, and mortality. Yet to understand it, we must approach the topic with a calm and clear perspective. This is not about advocating for it or advocating against it, but about explaining what it is, how it functions within our society, and the principles that guide its application. It is a response to the reality that for some individuals, the experience of living with a severe and incurable condition can become a form of suffering that they find intolerable. MAID offers a legal pathway for these individuals to have a measure of control over the final chapter of their lives, a choice that was unavailable to Canadians just a decade ago. The existence of MAID in the Canadian healthcare landscape forces us to confront complex questions that we might otherwise prefer to avoid. It challenges our traditional notions of medicine, which has historically been focused exclusively on preserving life and alleviating illness. Now, medicine is also tasked with navigating the difficult terrain of facilitating a peaceful death when a person's suffering becomes unbearable and irremediable. When we discuss medical assistance in dying in Canada, it is essential to understand that it is not a single, uniform procedure. The law defines two distinct approaches, or paths, that an eligible person can take. The first, and by far the more common of the two, is known as clinician-administered MAID. In this scenario, a physician or a nurse practitioner directly administers a series of medications that will cause a peaceful death. The process is deliberate and controlled, designed entirely around the comfort and dignity of the person. Typically, this involves the intravenous administration of powerful sedatives, which gently guide the person into a deep state of unconsciousness before other medications are given to stop their breathing and heart. The second path is self-administered MAID. Under this option, the physician or nurse practitioner prescribes the necessary medications, but the person takes them themselves, without the direct physical assistance of the clinician at the moment of ingestion. The medical professional provides the means and the detailed instructions, but the final act is performed by the individual. This form of MAID is significantly less common in Canada. The reasons for this are complex, but they often relate to the patient's physical ability to self-administer the substances, as well as the psychological comfort of having a trusted clinician manage the final moments. The self-administered option ensures that the principle of autonomy is upheld to its fullest extent, placing the ultimate control directly in the hands of the person. The choice between these two forms is a critical part of the MAID discussion between a patient and their provider. For some, the idea of a clinician administering the medication provides a sense of security and peace, ensuring the process is handled with medical precision and that no unforeseen complications arise. It removes any burden of action from the individual in their final moments, allowing them to focus on saying goodbye to their loved ones. This path is often chosen by those whose physical deterioration has made the act of self-administration difficult or impossible. It is a final act of care provided by the medical system, intended to bring a gentle end to a period of intense suffering. The legality of medical assistance in dying in Canada is relatively recent. It stems from a pivotal 2015 Supreme Court of Canada decision, Carter v. Canada. The court ruled the Criminal Code provisions prohibiting assisted dying were unconstitutional because they infringed the charter rights of competent adults suffering from a grievous and irremediable medical condition. That landmark ruling compelled the federal government to create a legal framework. The first federal law, Bill C-14, was passed in 2016. It established the initial criteria and safeguards. The legislation shifted assisted dying from the shadows of illegality into regulated end-of-life care. In 2021, the legal landscape evolved further with Bill C-7. That amendment responded to a Quebec Superior Court ruling. Most notably, it removed the requirement that a person's natural death must be reasonably foreseeable. This change opened eligibility to people suffering from chronic, debilitating conditions who weren't necessarily near the end of their lives. At the very heart of Canada's MAID legislation is the concept of a grievous and irremediable medical condition. This is not a casual phrase, but a specific legal standard that a person must meet to be found eligible. The law breaks this standard down into 4 distinct components. First, the person must have a serious and incurable illness, disease, or disability. This establishes that the condition is not trivial or temporary. It could be a neurodegenerative disease like ALS, a late-stage cancer, or severe organ failure. The incurability aspect is key, meaning there are no known treatments that can reverse the course of the underlying condition itself. The second component requires that the person be in an advanced state of irreversible decline in capability. This speaks to the functional impact of the condition on the person's life. It is not just about the diagnosis on paper, but about the tangible, progressive loss of physical or cognitive abilities. The legal framework for MAID in Canada was not designed to make the process easy or quick. It was designed to make it safe. To this end, the law embeds a series of robust safeguards that must be meticulously followed before MAID can be provided. The most critical of these is the requirement for 2 independent assessments. The person's request cannot be approved by a single doctor or nurse practitioner acting alone. A second, independent practitioner must also conduct a full assessment of the person and review all relevant medical information. Both assessors must come to the same conclusion, that the person meets all of the eligibility criteria laid out in the law. This 2-practitioner rule is a fundamental check against a single point of error or subjective bias. For many people, the most intimidating aspect of MAID is the unknown of the procedure itself. When a person has been approved for clinician-administered MAID and the chosen day arrives, the process is designed to be as peaceful and dignified as possible. It is not a sterile, rushed event, but a final, planned moment of care. The procedure can take place in a hospital. It can take place in a hospice, or, very commonly, in the person's own home. That choice is often left to the individual and their family, allowing them to be in a familiar, comforting environment, surrounded by the people they love. The medical team works to create a calm atmosphere, respecting privacy and time for final goodbyes. The medical process itself is methodical and follows a clear protocol. The physician or nurse practitioner will first ensure that the person still wishes to proceed. This is a final opportunity to change their mind. Consent must be ongoing up until the last moment. Once consent is confirmed, the clinician typically inserts an intravenous line. The first medications administered are powerful sedatives or anesthetics. Examples include drugs like propofol or midazolam. These drugs do not cause death. Their purpose is to induce a deep state of unconsciousness, similar to what a patient would experience before major surgery. From this point forward, the person is no longer aware or capable of feeling pain. Once fully unconscious, the clinician proceeds with the next step. A second set of medications is administered through the IV line. These are typically paralytic agents, which cause the muscles to relax. Including the diaphragm, breathing stops as the muscles relax. This cessation of breathing is what ultimately leads to the heart stopping. In some protocols, a third drug may be used to directly stop the heart. The entire sequence is designed to be smooth and painless for the individual. For family members, it's often described as watching their loved one fall asleep and then simply ceasing to breathe a few minutes later. In a topic as sensitive as medical assistance in dying, misconceptions can easily arise, leading to fear and confusion. It is therefore just as important to understand what a MAID is not, as it is to understand what it is. First and foremost, MAID is not a response to a temporary crisis or a moment of despair. It is not an option for someone experiencing treatable depression. It is not an option for someone experiencing a recent bereavement. It is not an option for someone facing financial hardship. The legal criteria specifically require a grievous and irremediable medical condition. This means the decision is rooted in a lasting and severe medical reality, not a transient emotional state. The safeguards, including multiple assessments and reflection periods, are there for a reason. The legalization of MAID forces us to navigate a complex ethical landscape where deeply held principles can appear to be in conflict. At the forefront of this debate is the principle of individual autonomy, the right of a competent person to make their own choices about their life and their body. Proponents argue this right should extend to the end of life. They call it a compassionate response that respects a person's dignity, allowing a peaceful, chosen death rather than a prolonged, intolerable suffering. Denying this choice to someone with a grievous, irremediable condition is to condemn them to a fate they do not want seen by proponents as a form of cruelty. Opponents cite the sanctity of life and the fundamental role of medicine. Medical assistance in dying in Canada is a carefully constructed legal and medical process, born from a societal desire to address profound suffering at the end of life. It is not an open door, but a narrow path, accessible only to those who meet a strict set of eligibility criteria. It comes in two forms: clinician-administered self-administered complaints. Both are governed by safeguards to protect patients and ensure decisions are voluntary and informed. The requirement for two independent assessments, the formal consent process, and the mandatory reporting mechanisms all work together to ensure this profound choice is made with care, deliberation, and oversight. Ongoing, careful, respectful conversations are essential as Canada refines its approach to this deeply personal decision.